Well, good evening. I'm very happy to talk to you, to members of the Oxford Alumni Osler Club, I think it's called. As an old retired neurosurgeon, inevitably, I'm going to talk a bit about the past, but I don't want to sound like a whinging old man saying things were better in the past. The point is they were different in the past in the NHS. I joined the NHS as a junior doctor at the age of 30 in 1979, and I started training as a neurosurgeon 2 years later. And there's that famous, rather cryptic quotation from the novelist L.P. Hartley, "But the past is a foreign country. They do things differently there." And over the more than 40 years I've been involved in the NHS, I still teach, although I no longer see patients. There are some enormous differences, huge changes, although some things have not changed, some things are better, some things are worse. And I'll try to illustrate this a bit with stories from my own career. Now, I started as a senior registrar in neurosurgery at what was then a very famous single specialty neurosurgical neurological hospital called Atkinson Morley's in Wimbledon. It was called Atkinson Morley's because a hotelier called Atkinson Morley had been an inpatient at St. George's Hospital at Hyde Park Corner in the 1830s, was distressed, or maybe earlier, it was distressed by the sound of all the horse-drawn traffic outside. And when he died, he left in his will a significant sum of money, both for fellowships for the Royal College of Surgeons and for a convalescent hospital to be built in the leafy green village of Wimbledon, as it was then. And this photograph is one of the famous photographic pioneers, Fox Talbot, one of his first photographs taken in 1844 of Nelson's column being erected. And there you can see in the back, it says Morley's Hotel. And that was Atkinson Morley's Hotel and the source of his wealth. It was demolished years later and is now the site of South Africa House. And what was unusual about Atkinson Morley's was that it became a military head injury hospital during the Second World War under Wiley McKissick. And he basically converted it after the war into what was at the time one of Europe's biggest neurosurgical hospitals. He was, by all accounts, quite a tyrant. I was trained by many surgeons who've been trained by him. I often felt they'd all been left a bit scarred by the experience. I mean, I heard endless stories about him, but one was that once he appointed you, and if the appointment was purely on a one-to-one interview with the great man, and then you arrived eager, bright-eyed and bushy-tailed at AMH in Wimbledon for your first day, and he would refuse to recognize you for 6 months. He would walk past you in the corridor, sweep past you, just to make sure you totally understood where you were in the hierarchy. But he was a great, in a sense, a great entrepreneur and a man of great vision. He built the hospital up into this very, very major unit. It contributed more patients than anywhere else in the world to the groundbreaking international cooperative study on the natural history of aneurysmal subarachnoid hemorrhage. He was responsible for Hounsfield coming to AMH, where basically CT brain scanning was invented. And of course, Hounsfield got the Nobel Prize. And there you can see the more or less the first CT scan, showing, I think, a right frontal abscess. This was absolutely revolutionary. And for many years, AMH was hugely famous worldwide because this was where CT scanning came from. I started there as a senior registrar in 1986, became a consultant there in 1987. And you can see there, by the way, in the bottom picture is the first clinical CT scanner in the Science Museum and the Wellcome Collection in London. And that was a hospital more or less as it was when I was there. I ended up eventually as the senior surgeon there. And then in 2003, we were PFI'd into a rather unremarkable, dull new building, swallowed up by St. George's Hospital. So I had a very interesting experience of working in a small, dedicated specialist hospital, ended up being, where I was, to be honest, a big fish in a small pond. And then I became a very small fish in a very big pond. So psychologically, that was quite interesting, but it was also extremely interesting to see, the consequences of practicing medicine in a very, very big institution as opposed to a small one. The history of British medicine or London medicine in the past was all about small specialist hospitals. There was St. Peter's for GI problems, for GU problems, St. Mark's for GI problems. You had the separate heart hospitals. You had the Elizabeth Garrett Anderson and Princess Charlotte's for gynae. All these single specialist hospitals, with one or two exceptions, like Queen's Square and some of the heart hospitals, have been swallowed up into these great big machine block hospitals. I'll come back to the block thing at the end of the talk. The building, I believe, is now called the Atkinson Morley's Wing, hence my talk from AMH to AMW. It was going to be a bigger block-like building, but they ran out of money. And they ended up with these large balconies where they sort of no longer actually built clinical areas. So the hospital arrived, this hospital wing arrived with these very large empty balconies. And I'll come back to that question later. Now, I think one of the interesting things about working in a small specialist hospital, and I think it's pretty safe to say that any doctor who has will say they're very, very good places to practice medicine because you know all the staff. Now, my wife, Kate Fox, is an anthropologist. She tells me we shouldn't take Robin Dunbar's theory about primate brain size too seriously. Gibbons, for instance, are way out. But the Dunbar's idea, which made him very famous, Dunbar's number, is the size of the primate prefrontal cortex correlates well, maybe not that well, to the size of a social group. And the idea is that if you look at the size of our neocortex relative to the rest of the brain, we're right out here, and we've got the largest social group. And the idea of a social group being all these people, but you also understand all the connections between those people, all their social relations. And he suggests there's an actual cognitive limit determined by the size of our prefrontal cortex. I'm sure there's some truth in that, and certainly the number of staff at AMH was 180, very close to Dunbar's magic number of 150. It became very famous because the first analysis was looking at Christmas cards, and they discovered that nobody had more than 150 Christmas cards every year. And I think this is one of the reasons why AMH functioned so extraordinarily well. When we moved to the new hospital, I remember very clearly, some of the porters, some had resigned, and some came to the new hospital, and they'd stop me in the corridor and say, "Oh, Mr. Marsh, it's not the same. In the old hospital, when the nurses need to turn a patient," because of course, turning patients for bed sores is a very important part of neurosurgical nursing care and involves at least 4 or 5 people. And all the other nurses have to stop working to come and turn the one patient. And the porters would say, "Well, in the old hospital, we'd come and help, but now we're not allowed to." And we're told it's not in our job description, which I think in microcosm shows how when you move from a small, very friendly sort of personal hospital to a great big institution, there are significant costs which are completely missed by all the official cost-benefit analyses. So things are very different 30, 40 years ago. The consultants were, in effect, dictators whose decisions could not be questioned. I felt the guys who trained me were really sort of lonely gods. Some, I think, were not too scarred about, but they're very much on their own. It seems bizarre now, but the people I worked, they never consulted each other when they had difficult cases. Each had to be a complete sort of monotheistic religion on its own. I remember once the old AMH, when I was a senior registrar, the 2 consultants, there were only 2, well, there was one other one who didn't do any work. By mistake, they coincided on a ward round, and it was like sort of repelling magnets. They were almost physically thrown apart. You couldn't have 2 gods on the ward at the same time. I thought it was very, very striking. The juniors worked madly long hours. I never worked less than 1 in 1, which actually was illegal, or 1 in 2 throughout my training. I must confess, I'm afraid I liked that. It appealed to me, but I don't think it's good. And I'll come back to the question of junior doctor hours and the EWTD later. But you did an awful lot of operating as a junior. It was pretty brutal. It was brutal on you. It was brutal on the patients. There was really very little consultant supervision, at least with most of my trainees. I had one trainer who was wonderful. But the tradition was still very much of a see one, do one tradition, which is very effective, but it has problems. On call, the consultants never came in. I, as the senior registrar, handled everything. In effect, I was like a consultant really now. And on call, there'd be a senior registrar, I got residents, this is an American side. There'd be a senior registrar, a junior registrar, and an SHO. And we have this little team who would handle all the emergency work. And like any doctor of my age will say, now what's the greatest loss for junior doctors now is they don't have the firm. And of course, the firm, where you had your little hierarchy, your little family, did depend on working very long hours and was essentially destroyed particularly by the EWTD. And I think probably the cost has been greater than the benefit. There was excellent nursing. I mean, the nursing in my department, I'm no longer there officially, but I go there unofficially. It's still very good. But again, you could see it was a huge benefit of being a small hospital where everybody knew each other. And it was amazingly efficient. I mean, there were 10-minute turnarounds between cases in the operating theatre. I looked up one of my diaries. I've kept a diary all my life. My diary is really what my books were based on. And I came as one comment, a fine list yesterday: aneurysm, endoscopy, meningioma, MVD, and a back. And that would be inconceivable now to get through so much operating. And it wasn't that I hurried. I was a fast surgeon because that was the tradition I trained in. You had to be fast to get through the day's work. But it was because of these immensely efficient turnarounds between cases. I was therefore hugely amused. And I saw last week in the Times a report from Guy's Tommies saying, London hospital cuts waiting list with innovative system. That basically all they were doing was having minimal turnarounds by having an anaesthetist in the anesthetic room, anesthetizing the next case, while another anesthetist was finishing the previous case. So you had very, very quick turnarounds. But this was based on money. It was done at weekends and it cost money. You pay the staff to come in. And what was so striking 30 or 40 years ago was we got through this enormous workload without extra money. And it was based partly on lack of, but very much more deferential society. So as the consultant surgeons ruled the roost, but there was a willingness to work extra hours without feeling you had to be paid for it. The concept of public service, of vocation. I don't want to get too dewy-eyed about this, but I think that has changed with the new contracts for doctors as well as for everybody else. So continuing what was different in the past, again, it seems very strange. This is a major weakness, I think. There was a minimal formal teaching. You were left just to learn by watching. You read things up on your own. You didn't have the internet, of course. I mean, I literally can remember doing operations with a standard neurosurgical textbook in front of me. And that is inconceivable now. There were no proper mortality and morbidity meetings or equivalent, which again, although I'm very skeptical often about how M&M meetings work out in practice in the modern day and age, they obviously should be an essential part of safe modern medicine. Litigation was extremely rare and never talked about. Maybe they whispered in the corridor that Mr. So-and-so is being sued. Amazing. I would tell my colleagues in recent years, well, if you're not being sued, it means you're not doing any work. And again, I'll come back to this problem of litigation and the cost of the NHS later on. There's a very high threshold for tolerating bad outcomes. Patients were much less likely to complain, they were very deferential, and bad results were buried and brushed under the carpet. To some extent, maybe it's gone to the other extreme now with all the SUIs and DATEX and things like that. but I wouldn't want to justify the way things were run in the past at all. In 1987, when I became a consultant, there were only 3 consultants and 6 operating juniors and 2 SHOs. And there were 3 dedicated ODAs who'd worked in the department for years, knew everything, every instrument, they could set everything up. They were fantastically efficient. And we lost them when we moved to a big new hospital because the management was obsessed with efficiency and wanted the ODAs to rotate around all the different surgical departments. So our dedicated ODAs didn't want to do that, and they all left. And it's a problem. They became a sort of jack of all trades and a master of none. And again, the basis of really good teamwork is knowing people and working together for long periods of time. It's a sort of pseudo efficiency if people are being rotated around and having a little bit of this and a little bit of that. And we did about 1,000 operations a year. Now there are 3 times more consultants, 4 times more consultants, an actual army of registrars and fellows working in their VWTD week. So their learning is hugely reduced. I mean, surgery is a practical craft, and you learn it by doing it. So the rate at which surgeons are learning and training now is very, very slow compared to the past. I think most neurosurgeons in this country now, and other specialties as well, are lucky if they get to work, they get to operate 1 or 2 days a week. I'm told there are even jobs now where they only have 1 list a fortnight or a weekend. I mean, it's extraordinary. And the number of operations has gone up, but clearly there's been a huge drop in productivity. There I am, enthusiastic young neurosurgical SHO at the Royal Free Hospital in the days when we wore ties, which obviously I wiped and rubbed in my patients' wounds, and a scruffy white coat. Now, I thought when I went into medicine, into neurosurgery, but it was all about great men. I wanted to be a great man. My anthropological wife says, well, I try to pretend I'm not, but she says I'm a typical alpha male, silverback gorilla, typical surgeon. And I saw neurosurgery as a history of great men: Cushing, Dandy, Lexell, Kearns and Oxford, Godley, and more recently the American Bob Spetzler, who was at the Barrow in Phoenix, now retired. But now, 30 or 40 years later, as medicine as a whole has changed to some extent, my view of surgery is completely different. And I see it as above all a team, or it should be a team activity, not just being nice to the theatre nurses and being polite, which you should be, but actually having good colleagues, good medical colleagues, where you share difficult cases, discuss difficult cases, don't barge into things on your own, thinking you know all the answers. So team working, although it's a very obvious truth, it needs to be reiterated. You'll make better decisions because we all think too well of ourselves. There's a fundamental rule of human nature. Other people are better at seeing my mistakes than I am. And if I'm well known because of my first book, a lot of it's about mistakes I made. And a lot of them are cases where if I'd said to one of my colleagues, hey, what do you think? They would have said immediately, Henry, look, it's obvious what the problem is, particularly with postoperative infections, which can in brain surgery present in very odd ways. So your colleagues may have more experience than you. They may have seen the odd presentation. But more importantly, they don't have my cognitive biases. They don't find it as difficult to think badly of me as I do. So it's a hugely important aspect to proper team working. So you'll make fewer mistakes. But team working is not about agreement. Team working, you need grit in the oyster. Team working is about disagreement, discussion, and then with good leadership, you reach some kind of consensus. Very important for your mental health. I think being a doctor now is much more stressful than it was when I was a young doctor. There's so much more management, supervision, oversight, criticism in the media, all the SUIs and datexes and this, that, and the other. And if I was a junior doctor now, I'd be sort of paralyzed with fright, I think. But your best treatment for the stress of the work is having good colleagues. I'm not saying we should all be having therapy and weeping on each other's shoulders, but believe you me, when you've had a terrible result, and we all have them, neurosurgeons probably more than many other specialties because of the nature of the brain and the brain's limited capacity for recovery from injury. To know you have colleagues who've been through it and understand, you don't necessarily even have to tell them very much, but it is enormously important to realize you're not alone. And all of us, or almost all of us, I know the stereotype of surgeons, particularly brain surgeons, is they're all psychopaths without any empathy, but that's not true. What we vary in is the extent to which we show our feelings or admit to them. But all of us have had disasters. GPs will have missed a diagnosis of cancer, for instance, which is terribly painful. And it is very helpful to have colleagues who also have problems and tell you, look, you did your best, these things happen, even if you made a careless mistake. I make careless mistakes because I'm a human being, but it's very, very hard to admit to it, of course. Much better for training and learning. If the consultants all get on together, there are not lots of rivalries, often based on private practice, money, things like that, the juniors will get a much better experience of training and learning. Better use of stretched resources. If you're short of theatre time, as certainly almost all of us are now, I say us, but I'm retired, you have to get together every morning and decide who's going to operate, and it's really important if the consultants get on together, as happens in my department, and can find amicable solutions to these very difficult problems of who's going to do the next case. But of course, there's a fundamental rule about having good colleagues, and teamwork is about having good colleagues, and that is, if you're not a good colleague yourself, you won't have good colleagues. It's necessary, but not sufficient. Of course, you only need one lousy colleague, one rotten apple, to upset the apple cart, to mix the apple metaphors. But it still is, charity begins at home, and you have to really think very carefully. I mean, when I talk about leadership to trainees or consultants for that matter, I always say you must never lose your temper. Don't lose your temper. You often will be very angry, but you've got to learn to suppress it. It doesn't work. It makes everything worse. But there are problems in team working. I mean, it's not a perfect panacea by any means. The team can be too big. In my days as a criminologist, and I did PPE and studied Soviet politics under Archie Brown at St. Anthony's, you knew when something was brewing in the Kremlin because the Politburo would be made bigger, because of course big committees don't function very well. It's one of the criticisms of our present government, that the cabinets got bigger and bigger. And then it means, of course, you have to have an inner cabal who actually make the decisions. So size is important. If membership is changing over all the time, rather like we've had 5 prime ministers in the last few years, this does not lead to effective teamwork and decision-making. It needs good leadership above all. I mean, good leadership is, the modern mantra is about support and empowerment. It's not about dictatorship. All the business literature about leadership doesn't entirely apply to medicine, because there is, of course, the problem of responsibility. I'll come back to that in a moment. And then there's also the phenomenon of groupthink, which is well recognized by psychologists, where essentially a group of people will put the interests of the group ahead of what individually they think is probably best. And I can illustrate that with a painful case. But that's the slide showing the modern view of leadership. On the right, the leader supports and empowers, and on the left, the leader dictates. But the problem with that, of course, is when, in the clinical context, when a patient comes to harm, who is responsible? Well, it has to be the leader. And that means the leader, the clinical lead, does need some extra protection, some extra deference, perhaps, than in other, because medicine is so serious and patients die and can suffer terrible harm. But in terms of groupthink, well, that's hemangioblastoma. It's basically a mass of blood vessels. This is a man, just before I finally retired from part-time working, who presented with acute hydrocephalus, emergency, very ill. And these are benign tumors, but they're the only time in brain surgery you need to do an en bloc resection, because if you go into the tumor, they bleed horrendously. In fact, the historical literature states there's a 50% mortality. So you have to approach them very carefully. And this case was presented to one of my junior colleagues at the multidisciplinary team meeting. I was there. He didn't want to operate, basically. He was a bit scared. And I was reaching the end of my career. Maybe I was just feeling old and, didn't want to go on doing these very dangerous operations I've been specializing in for so long. But I knew actually it should be operated on. I'd removed tumors like this myself. I could do it. Sure, there's risks, but for me, it was absolutely straightforward. But I didn't say that. I just sort of, the radiotherapy said, oh, we can treat that, which is not true. I mean, that's not suitable for radiotherapy. But basically, I didn't want to upset my colleague and hurt his feelings, and I went along with the group. The patient did disastrously. He was left more or less in this long, complicated story, but because he didn't have proper definitive surgery. So that's an example of groupthink, and it's one of the many skeletons, or one of the many gravestones in my inner cemetery, which the French surgeon Le Riche wrote so eloquently about. All surgeons have an inner cemetery to which they must go from time to time. And then, of course, with team working, particularly perhaps with surgeons, but they're human beings, there's a problem with human beings, particularly with men, I'll come back to that, is interpersonal conflict and jealousy. Now, I like to illustrate the surgical ego with Snow White and the Seven Dwarfs and the evil stepmother, mirror, mirror on the wall, who is the best brain surgeon of them all? And particularly when we're young consultants, we know there are other people actually who are better than we are. But if we don't take on the difficult cases, how do we get better ourselves? And this, of course, is the problem, that we have a duty not just to the patient in front of us, as stated rather vacuously by the GMC. We have a duty to our future patients. We have a duty to become better. And when we're senior and older and training the next generation of surgeons, we have a duty to their future patients. And you cannot do that without exposing the patient in front of you to some extra risk. So we all know that inwardly. I suspect it's an uncomfortable truth many of us suppress, but it's a problem, and it's difficult to discuss outside medical audiences. If you have good team working, where the senior, more experienced doctors will work with the junior ones, as is increasingly happening, I'm happy to say, certainly in my department, because the new consultants are so inexperienced and know that and accept it, then you can almost square that circle. And of course, the Bristol pediatric heart scandal was sort of this problem, but on a much bigger, more difficult scale, which I suppose is why the Royal College and other people tried to sort of brush it under the carpet, which of course was wrong. So it seems to me, looking back at my career, that I was on a tightrope, trying to find a balance between lots of conflicting objectives. But rather than being a single tightrope, there was a whole series of tightropes, and here's a list of them. And if you're on a tightrope, of course, you don't want to look down too much, you may fall off. And the first thing is compassion versus detachment. There's much talk about doctors aren't empathic enough. Well, the strict meaning of the word empathy is to actually feel what somebody else feels. And clearly, as a surgeon, any branch of medicine, your patients don't want you to burst into tears when things are going badly. And we have to be detached, and we're going to witness and sometimes be responsible for terrible suffering. And we mustn't we mustn't become dehumanized, but at the same time, somehow, we have to control our feelings. And it's very difficult. You can get too involved. I tell stories in my first book, Do No Harm, but certainly one case where I shouldn't have operated again, but I couldn't bring myself to look the family in the eye and say, it's time to die. It's very difficult. And over-treatment, of course, is a big problem in modern medicine. But at the same time, I can think sometimes when I spoke really badly to patients and their families, I become too detached. Difficult balance. And we have to find a balance, as I was saying earlier, between being fierce, ambitious, alpha males or alpha females, as is the case now, and being good team workers. And that, again, is not easy. And sometimes we'll have colleagues who aren't actually that good, but they're not so bad we can actually go to the management and say, this man should be sacked. And yet we know these are people we wouldn't really want our family to be treated by. And we don't want to rock the boat. I mean, in my own hospital, the cardiac department got into a terrible problem with interpersonal rows. And the hospital, the department suffered greatly as a result, where perhaps, you had to put your conscience a little bit to one side for the sake of the department as a whole. Again, a difficult, and again, in a time of stretched resources, the GMC now says, well, your patients may come to harm, and that and the other. Very difficult. And you've got to find a balance between money and vocation. I mean, that one of the great joys of the NHS is we're not paid piece rates. So we don't have to see patients as a source of income. Well, yes, if you're in the private sector, but that doesn't apply to too many of us. And I work in many impoverished countries, so state health, I still work there. Pakistan, Sudan, have that in the past, Ukraine a lot, Albania, where state healthcare is so poor, the doctors are all paid money under the table, because the doctors aren't paid enough by the state to live. And they depend upon what you could call informal co-payments. Other people would call it corruption. It's a balance. And that's a problem for some countries to decide. And we all think we know our colleagues who really were slightly more interested in what was best for their bank balance and what was necessary best for the patients. And the big problem with surgical decision-making, of course, is surgical decision-making is balancing the risks and benefits of surgery against the risks and benefits of not operating. And these are probabilities. These aren't simple mathematical additive subtractive facts. And we know from the work of the great psychologist Kahneman, Nobel Prize and all that, and other people, that we have these so-called cognitive biases where our estimation of probabilities, our estimation of the future is unconsciously influenced by various factors, our optimism bias, loss aversion, things like that. And one of these, of course, is money. And it's easy to overestimate the risks of doing nothing and underestimate the risks of operating. You're not wrong. You say, well, I said it was 90% chance it'd be all right. Patients left rectal, I said there was a 10% chance, a bit like the weather forecast. So this is difficult. Again, we have to be careful. And again, part of another balance is we have to be very self-competent in surgery, but in all branches of medicine. We have to pretend often to patients to a degree of confidence and competence, and particularly when we're young. We know we don't really have. There's a lot of acting involved in medicine. And of course, the best way of lying or deceiving other people is to deceive ourselves, self-deception. So I say a little bit, ironically, self-deception is an important clinical skill, but within limits. And it can, of course, become a problem when you're an independent consultant and no longer being supervised. And we have to find a balance between that necessary self-confidence and being endlessly self-critical. And when things have gone badly, we must drag ourselves to the point and say, what could I have done differently? Would it have made a difference? It's so tempting to say, well, this was going to happen anyway. Very difficult. And when talking to patients, particularly with cancer, you've got to be honest, and yet you've got to give them hope. I illustrate this problem of honesty with my anthropological wife, who was up at the JR a while ago having a blood taken. She's got Crohn's disease, and it was done by a young doctor who left the usual line of bruises and pinpricks most doctors our generation are familiar with. Nowadays, it's all done by the much more skilled phlebotomists. And then he said to Kate, oh, I'm terribly sorry. I haven't really done this before. Which, of course, was terrified her. And what he should have said was, you've got terrible veins. And then she would have been happy. But what he probably didn't realize, and I didn't really understand this very clearly when I was younger, he faced an ethical problem. At what point do you say to the patient, I'm sorry, I'm making a mess of this. I'm going to go and ask for a more senior person to come and do this. And I can think of various really very terrible mistakes I made because I went on. I should have stopped. I should have admitted, no, I need help. So when I'm asked by often, when I'm talking to particularly medical students and junior doctors, what would be your single bit of advice to doctors? I say, ask for help. And that was not the ethos I was trained in 30 and 40 years ago. Ask for help, terribly important. And if you have good colleagues, it will work. And then on a similar note, if you do difficult surgery as I did, are you being brave or are you being reckless? There's a story in my first book of a woman with a terrible benign clival meningioma. They went to see Lindsay Simon, certainly the most famous, and or maybe certainly one of the best neurosurgeons in the country. And he rang me up and said, oh, Henry, this is a young man's operation. So I thought, wow, great, I've been blessed by the Pope to do this operation. And it took about 18 hours, and at 2 o'clock in the morning, when I was no longer operating my best, and I wasn't quite the Superman I like to think I was, I tore a perforator off the basilar artery. And I saw her 10 years later. She was still in a persistent vegetative state. And it took me a long time to recover from that and start, learning, getting help, how to deal with that particular sort of very rare, very difficult tumor. And part of the honesty and pretense, again, is hope and realism, when to stop treatment, always give patients hope. There was a wonderful general surgeon at the Royal Free when I was a medical student. I had no wish to become a general surgeon, but he was super, called Adam Lewis, who put it very succinctly. You must never lie to patients, but you must never deprive them of hope. And then finally, work versus life. I had no life. Well, I did, but I was on 1 in 1, 1 in 2. I'm afraid I liked it. I was at work almost all the time, more or less lived in the hospital. That was one of the reasons why my first marriage failed. And I wouldn't want anybody to go back to working like that. But I do think the pendulum has swung too far in the opposite direction. So reaching the end, a nice paper recently published a few weeks ago showing that women surgeons at 1 year's follow-up had lower complication rates than men surgeons. I don't know how replicable the study is, but it certainly fits my experience. I've had an increasingly large number, but still not enough, women trainees, and they're all outstanding, quite outstanding. And I think because, to be honest, they were more careful and slightly more risk averse than the men. So I'm all for more women in surgery and medicine. On a similar note, the great Dutch primatologist, Frans de Waal, you may have read some of his splendid books, who has this large bonobo colony in San Diego, where bonobos used to be called pygmy chimpanzees. They are our closest evolutionary relatives. We have a common ancestor either 3 million or 5 million years ago, I can't remember which, but they're closer than ordinary chimpanzees, the bigger ones, who are very violent and aggressive. Bonobos are very peaceful. And he thought they would put one of his postdocs in an operating theatre, I think in San Diego, using the same observational metrics they used for studying conflict and cooperation in the bonobo colony. And they said these metrics worked very well, and they drew various conclusions. And that was conflict was always directed downwards, senior people, excuse the English, shitting on the ones lower down. There was more conflict, and there were more male members in the surgical team, and there was less conflict when the team leader, the surgeon, was of a different gender from the majority of the team, which is interesting. But we are primates, and it's worth remembering that. Now, briefly on the NHS, Wes Streeting says the NHS must reform. Everybody's saying it must reform. It's very hard to actually find any suggestions as to how it should be reformed. And nobody's saying, well, there's this wonderful country somewhere else which spends less money on healthcare than we do and has better outcomes. So I think the NHS needs reform, but it's a very difficult problem. So I'll make 1 or 2 suggestions. And I'm running out of time, so I'll speed up. Obviously, we need more staff and more money. people say, yes, this country's highest taxation ever, but actually we have a lower tax burden than most European countries overall. And it's quite clear, if you look at the King's Fund, the Health Foundation, that we spend less money on healthcare, particularly under the present government, than countries in Europe we'd like to think are our equals. I'd abandon the European Working Time Directive. Again, this would cost money. You'd have to pay junior doctors more to work longer hours. But certainly for surgery, I think it would be very important and very good for doctors' morale, I think. I think the shift system where you work sort of hours on, hours off, you get pushed around from pillar to post. You don't get to know the nursing staff properly. I think it's been very bad for morale of junior doctors, and I think it's one of the contributing factors to the present unrest and strikes. Obviously, community care needs to be sorted out, the bed blockers. All governments have said this for years. For some reason, they've done nothing about it. Personally, I thought Theresa May's mansion tax was reasonable, but it got completely shot down. So it shows the political difficulties of trying to sort these things out. I would love to see some return, not complete return, to the much greater autonomy senior doctors had in the past, but I'm not sure how that can be achieved, to be honest. But I think it's been very bad for productivity and morale generally. The fact that my consultant colleagues sort of wading through a morass of more and more documents, paperwork, computer time, and very second-rate computers. In my own hospital now, the consultants have the 14-character passwords changed every 6 months, and it takes half an hour to get the computers booted up before you start an outpatient clinic. I mean, it's grotesque, and that's all because of lack of investment in IT. And I would also try to imitate what goes on in Sweden or New Zealand with no fault compensation. But obviously, that's a lot of vested interests against that. It's complicated. There are no easy answers. As the litigation, it's about 2 to 3% of the NHS budget goes on litigation. A significant proportion of that goes to the lawyers. I'm not against lawyers. I work in many countries where there's no rule of law, where the judges are corrupt. So the rule of law is incredibly important. But something's gone awry with the common law adversarial system of settling medical litigation. And besides, natural justice, if I operated and left somebody paralyzed, if it could be proved it was my fault, the patient will be recompensed to the extent money makes up for things. But if it wasn't my fault, the patient gets nothing. And yet the suffering involved for the paralyzed patient is exactly the same. Oddly enough, just 2 weeks ago, The Economist says healthcare costs in the OECD are no longer rising, the so-called iron law. The Economist wasn't quite sure why this might be happening, didn't discuss the possibility. It might be the outcomes are getting worse, but it's unclear, and it's actually quite interesting. But maybe healthcare costs are going to plateau in some way. I would say this of my own career. I loved my work. I still love teaching, and I don't see patients now, not in this country, but I think it's a huge privilege to be a doctor. It comes at a price, both in terms of management and bureaucracy, and also in terms of patient harm, depending on your specialty. But I can't imagine a more wonderful job than to be a doctor, particularly the sort of medicine I practiced. That's a child I operated on shortly before the pandemic in Lviv, in Ukraine, a benign cerebellar tumor. I was taking my colleagues through how to do it. It has been given some modern operating equipment by a wealthy Canadian Ukrainian. And what a privilege to, hang on, where are we? To stand with my trainees and colleagues at the child's bedside the next day. I no longer felt I was walking on water. I just felt an intense sense of relief that the operation had gone well. It is an extraordinary privilege. But the fact of the matter is, the next case I operated on next time suffered a terrible post-operative hemorrhage, basically because the post-operative care was terrible. And I hadn't dared to kind of query it and look into it. I just hoped everything would be all right. I was lulled into a false sense of security by the first case, and she died horribly locked in. It was just awful, only child of an only mother. So, but the point is, the triumphs are only triumphant because we have disasters. And I think what characterizes medicine as opposed to other professions is frequent failure. And the challenge of living with that, accepting that, learning from it, trying to minimize it and not deny it, I think is really, for me, what defines medicine and makes it, in a sense, quite wonderful and painful. The other thing I'm proud of is I introduced a morning meeting in my department many years ago, where we meet, not a handover meeting, where the consultants and juniors meet. We talk about the emergency admissions, we discuss the weather, we make jokes. And I introduced it because I was aware of the fact that junior doctors were starting to become a bit alienated and pissed off with the decline of the firm system. And I'm happy to say that now that I've left, the meeting has continued very well. So it did not depend upon me, even though at the time it was my meeting. And it's one reason why we all get, our department gets voted the best neurosurgical training department by trainees in the country. What's happened to the old hospital? Well, they were rich trash housing, luxury apartments with a nod to the past, Hounsfield Lodge and Ambrose House. And Jamie Ambrose was a wonderful neuroradiologist who did all the work with Hounsfield on CT. That was Hawkins Ward, the female neurosurgical ward. It's a listed building, so they couldn't demolish it. Now, it's a curious fact that hospitals, particularly in this country, but worldwide, are horrible places. They're architecturally awful. They're so terrible that even the statues throw up their hands in horror. Actually, that was St. George's up there, but I took this photograph when I was still on the staff, and I thought it might be politic to Photoshop it out. And shortly after I gave a big public lecture showing this slide, the statue disappeared, but maybe for an unconnected reason. Now, one of the things that many things I learned from the old hospital was the importance of a green environment and how wonderful it was that patients would get outside. I'd go to work and my patients would be sitting there on benches outside in a rose garden of trees. The windows could be opened. It was a much more therapeutic environment, even though it's a rather beat up old Victorian building than the modern thing we have pushed into. As I said at the beginning, they had to cut costs, ended up with these enormous balconies. Obviously, the first thing a manager sees when he sees a balcony is all the patients going to be jumping over it to their desks like lemmings. And nobody was allowed on the balconies. It took me years of emails, raising charitable money. It was a PFI building. The lack of interest, the lack of vision from both the hospital management and the PFI company, it was fascinating. It was obvious to me that this was a fantastic opportunity to improve the patient experience. And after many years, I was able to create this roof garden immediately outside the neurosurgical wards, much loved by the patients and staff. And during the pandemic, all the staff could get out there in their PPE to have a break from the terrible time they were having. So looking back at my career, the morning meeting and this roof garden, I am particularly proud of. And that is the end of my talk. Thank you very much.